Welcome to the next in the KDIGO Genetics and CKD webinar series. Today's episode is episode 10, Case Studies, How to Care for Patients with C3G and ADPKD. A big thank you to our audience for submitting questions ahead of the webinar today. Today's presentations will be followed by a questions and answer period. Today's speakers are Daniel Gale, University College London, United Kingdom, and Emilie Cornec-Le Gall, University of Brest in France. And now I'll turn things over to Daniel to get us started. Go ahead, Daniel.
Hello, thank you very much for the invitation to talk to you this afternoon. And I'm delighted to be able to talk about genetic diagnosis in C3 glomerulopathy. These are my disclosures that are not really relevant to the topic under discussion. I'm going to start by talking about two brief case vignettes and also pose some questions for you, really rhetorical questions, I guess, given the format. Then I'm going to talk about C3 glomerulopathy, its definition, pathophysiology and etiology. And then talk a little bit further about an approach to genetic testing, whom to test and how to interpret the results. But before we do that, I just want to address the question of why do genetic testing? And there are several reasons why this is advantageous. There's determining the cause of a patient's disease to give an answer to the question of why they've got, in this case, kidney disease, to predict prognosis and select treatment. So genetics can sometimes tell us which treatment will or won't be of benefit. And third is the facility to offer predictive testing to at-risk relatives. This might allow early intervention to improve outcomes. It might provide reassurance that an individual is not at risk of the family's disease. It can also facilitate reproductive decisions or even interventions. And of course, it can be useful in informing the decision of whether to donate a kidney. However, to be clinically actionable, a genetic test needs to reliably identify the molecular cause of a Mendelian disease. So the first case is a 23-year-old woman of North African and European descent who presents with an EGFR of 39 mils per minute and around 2 grams per day proteinuria. She has a background of type 1 diabetes mellitus, which was diagnosed at the age of 4. At the age of 16, she'd been noted to have proteinuria with elevated HbA1c levels, and at that time, very transiently, a slightly low C3, which normalized on repeat. A renal biopsy had been planned, but she didn't attend for that. At the age of 18, she underwent a tonsillectomy for recurrent infections. And around this time, her proteinuria was much improved. Her HbA1c was still elevated. By age 20, she'd been initiated on renin-angiotensin system blockade for a loss of nocturnal blood pressure dip. And at the age of 21, her EGFR had been 48 mils per minute with 1 to 1.5 grams per day proteinuria. Her HbA1c had improved on an insulin pump. So now at the age of 23, she's got an EGFR of 39, around 2 grams per day proteinuria. She doesn't have diabetic retinopathy or neuropathy, and autoimmune virology and monoclonal gammopathy screens were all normal, with a borderline low C3 and a negative C3 nephritic factor. She underwent a renal biopsy, which showed significant segmental glomerular sclerosis with mesangial hypercellularity and capillary wall thickening. Immunostains were positive for C3, especially on capillary walls, but not for immunoglobulins. And I don't have the images of the light microscopy, but the electron microscopy is shown here, where there are electron-dense deposits, mostly in the mesangial and intramembranous glomerular basement membrane, but there were some subepithelial and subendothelial humps as well. She also had evidence of diabetic changes, particularly with GBM thickening. On the basis of this biopsy showing C3 glomerulopathy, and I'm going to talk a little bit more about the diagnostic criteria, she underwent genetic testing for variation in genes associated with atypical hemolytic uremic syndrome, and this revealed no actionable findings. Of note, she did actually have a rare variant in CD46, the gene that encodes membrane cofactor protein. But this variant had not been seen before and is classified as one of undetermined significance. So this is a rather busy slide, but the green is the urine protein creatinine ratio, the grey is the serum C3 with the lower limit of the normal range in the dotted line, and the blue is the eGFR. The red dots represent the C3 nephritic factor assays, which initially at least were all negative. Over the following 8 years, the proteinuria, as you can see here, although it moved around somewhat, gradually improved. The eGFR stayed roughly constant, and the C3, if anything, increased. There was a trace positive C3 nephritic factor on 2 occasions. She received no treatment other than the renin-angiotensin system blockade. So that's the first case, or at least the first 8 years of the first case. So the second case is a 6-year-old girl who presents with a low serum C3, nephrotic syndrome, and renal impairment. Kidney biopsy showed C3 glomerulopathy in a dense deposit disease pattern with dense transformation of the basement membrane shown here, and C3 nephritic factor was negative. Approximately 1 year later, she was approaching end-stage kidney disease. Genetic testing of 9 complement regulating genes revealed a novel missense variant in complement factor B. This variant was also present in her father, who is well with a normal eGFR and no proteinuria. So the clinical questions are, firstly, whether the father should be precluded from donating a kidney by these genetic findings. Given that there's no other potential live donors, if the answer to this question is yes, the patient has to go on dialysis at the age of 7. The second question is, would your answer be different if the mutation was a nonsense mutation in exon 5 of the 18 exons of complement factor B? And the third question is whether you regret the ordering of the genetic test. So I've used words like MPGN, C3 glomerulopathy, and dense deposit disease, and this diagram here shows an approach to diagnosis. So MPGN refers to the light microscopic appearances of thickening of the capillary walls and mesangial hypercellularity. There are a number of disease processes that can result in these morphological appearances, including cryoglobulinemia, autoimmune diseases, chronic infection. Where there's antibodies and complement deposited in the kidney, this and no identifiable cause, this is termed primary immune complex MPGN. Where this light microscopic appearance is seen with complement C3 deposition, but insignificant or no immunoglobulin deposition, this is termed C3 glomerulopathy. And C3 glomerulopathies are subdivided into dense deposit disease, in which there's characteristic dense transformation of the glomerular basement membrane. And this pattern was formerly called MPGN type 2. And C3 glomerulonephritis, which includes cases previously categorized as MPGN type 1 and 3, and is characterized by discrete electron-dense deposits, which may be subendothelial or subepithelial. Typically, dense deposit disease is thought to result from defects of circulating complement regulation. So the question really is, what causes C3 deposition in the glomeruli in this setting? And this cartoon shows a simplified version of the complement cascade, where antibodies binding to an antigen result in activation of the classical pathway, leading to the production of C3b, which is cleaved from the abundant circulating precursor C3. C3b can activate the terminal pathway. It can act as an opsonin. It can also, by binding to activated factor B, cleave more C3 to generate more C3b in a positive feedback loop. This positive feedback loop is regulated by a number of proteins, including the circulating complement factor H and complement factor I, and membrane-bound proteins such as MCP. More recently, it's been appreciated that the factor H related proteins probably inhibit the function of complement factor H. So where there's immune complex MPGN, this usually results from increased antibody production, which may result from chronic infection, may result from autoimmune disease or monoclonal gammopathy or cryoglobulinemia. And this is not reported to occur in a Mendelian fashion. C3G, on the other hand, is defined really by alternative pathway dysregulation, where there's much less prominent immunoglobulins and C1q deposited in the glomeruli. It usually occurs as a sporadic trait, but familial cases and even Mendelian inheritance have been reported. It can be found in association with an underlying monoclonal gammopathy, particularly in adults, especially older adults. It's most commonly seen in the setting of a C3 nephritic factor, which I'll talk about in the next slide, and is also reported in the setting of monogenic complement disorder. And I've ringed the genes that have been associated with Mendelian inheritance of C3 glomerulopathy, and I'll talk in more detail about them just now. So C3 nephritic factors are a heterogeneous group of antibodies that bind to and stabilize C3BBB, the activating protein in the alternative pathway. They were first identified in hypocomplementemic dense deposit disease patient sera in the 1970s, and they're also associated with partial lipodystrophy, shown here in this image, and ocular drusen, shown here. Importantly, even very low levels of this autoantibody can be sufficient to stabilize C3BBB. So this autoimmune process can be very resistant to treatment and indeed hard to detect or exclude by clinical assays. There are also other autoantibodies that have been associated, including combined antibodies against factor D and C3b and other nephritic factors, which have been reported in a very small number of patients. Mendelian inheritance is not typically a feature of C3 nephritic factor positive disease, and there's no association with atypical hemolytic uremic syndrome. Interestingly, in one large series of dense deposit disease, 16% of the cases reported a relative with type 1 diabetes, which the authors report to represent a more than 100-fold increase on the expected population rate. So what about familial C3 glomerulopathy? Well, 12 years ago, we described endemic autosomal dominant C3 glomerulopathy caused by a CFHR5 internal duplication. We reported this in 11 Cypriot families, the first two of which are shown here, showing very clear autosomal dominant inheritance from families originally from various parts of Cyprus. This is actually quite a common cause of kidney disease in Cypriots and has implicated the FHR5 protein as important for the control of complement in the kidney. The CFH-related 1 to 5 genes have been associated with other molecular defects and C3 glomerulopathy. So there's a CFHR3-1 fusion protein, shown here. There's a CFHR2-5 fusion protein. There's a duplication in the CFHR1 gene and the internal duplication in CFHR5. And in all cases, these result in in-frame duplications of the gene that produce elongated FHR proteins that are detectable in the blood of patients. They all segregate as a dominant trait. And it's thought that gain of function mechanism explains the disease. So loss of function or indeed missense variants in these genes have not been shown to be pathogenic for C3 glomerulopathy and have never been shown, as far as I know, to segregate with Mendelian inheritance. These genetic rearrangements are not associated with atypical HUS, although different rearrangements in this gene cluster that disrupt complement factor H are. Familial C3G has also been linked to 2 other monogenic complement disorders. The first to be described is this very rare biallelic complement factor H mutations, originally described, I think, in this consanguineous family. Patients develop dense deposit disease with very low circulating C3 early in life. This phenotype has been recapitulated in mice and pigs deficient in factor H. And secondly, single families have been reported with specific mutations in C3 that seem to have an activating effect. And these have both been described in 2 affected cases in 2 families shown here. What about non-familial MPGN and C3G? Well, various studies have identified rare variants in patients, in complement genes in patients with C3G and immune complex MPGN, with 18% of patients in one French series having a rare variant, 43% of patients, these were a mixture of C3 glomerulopathies and thrombotic microangiopathies, and in an Italian series, around 18% were were found to have a rare complement variant sequencing these various complement genes. So if C3G is a monogenic disease of complement regulation, the implication is that we should be sequencing complement genes in patients as part of the diagnostic workup. This should influence transplant decisions, potentially precluding healthy relatives donating in the absence of a genetic diagnosis in the proband, as is practice for atypical HUS. And also patients should be treated with complement inhibition and not immunosuppression. However, in some patients, there seem to be overlapping causes of disease. So in the French series I mentioned earlier, they documented very clearly that C3 nephritic factors are very common in patients with dense deposit disease and also occur commonly in C3GN. The same paper also reported rare complement variants and multiple complement abnormalities identified in some patients. Interestingly, 46% of patients with a complement variant also had a C3 nephritic factor in this study. And C3 nephritic factors were also identified in immune complex MPGN, suggesting a degree of overlap between these histologically differentiated conditions. So there are some observations that are not easily explained by a monogenic etiology for C3 glomerulopathy as it's usually encountered. Firstly is that C3G is not usually familial, except in the Cypriot families that I mentioned earlier. The second is that family history of type 1 diabetes is much more common in dense deposit disease patients than in the general population. This is very difficult to square with a monogenic complement defect explaining dense deposit disease in a high proportion of these people. And thirdly, many people with C3 glomerulopathy have a C3 nephritic factor, and the frequency of a rare complement variant in these individuals is similar to those without a C3 nephritic factor. So to study this in collaboration with colleagues across the UK, studying a large number of rare diseases shown in this table here, including neuropathic pain diseases, intrahepatic cholestasis of pregnancy, and hypertrophic cardiomyopathy, we undertook whole genome sequencing in a total of 13,000 people. The experimental design is that patients gave informed consent for whole genome sequencing. They gave a blood sample, they had their phenotype captured by HPO codes, and diagnostic grade gene variants were discussed in a multidisciplinary team, including geneticists, and fed back to patients. Where diagnostic grade genes weren't identified, various types of association analyses and functional studies were undertaken in the hope of identifying molecular diagnoses. The genetic ancestry was closely matched to UK census ethnicity data, and this study was published 2 years ago. The primary MPGN C3 glomerulopathy cohort comprised 146 cases of European ancestry who were matched with 6,369 individuals without evidence of kidney or autoimmune disease. And in fact, between 6 and 7% of both of these groups had rare complement gene variants shown in this table here. And when we looked more closely at the individual complement genes, we didn't see enrichment in people with MPGN or C3 glomerulopathy in any of these genes compared with controls. What we did observe, however, was strong evidence of enrichment in a particular HLA type, DR17, which is also strongly associated with type 1 diabetes. And this, in fact, was replicated in a second cohort. The HLA association was present in individuals with various types of C3G with or without a C3 nephritic factor documented. So we concluded from this study of 146 cases that in the absence of Mendelian inheritance, in these cases were all sporadic cases, 1 or 2 of them had a family history, but none showed Mendelian inheritance, and that C3G is far more likely to have an autoimmune than a monogenic cause. With 0 out of 146 monogenic cases in this series implies a 95% chance that the true figure of monogenic C3 glomerulopathy represents less than 3% of UK cases. So how does this, what are the implications for genetic testing in clinical practice? Well, since the positive predictive value of a test is the ratio of the true positives to the sum of the true and false positives. This is heavily dependent on the prevalence of the condition in the population being tested. It's shown by this formula here. If you graph this, what you can see is that as the specificity, that is the likelihood that a variant is pathogenic, changes, the likelihood that a positive result being a true as opposed to false positive result changes on the y-axis here. So given that variants of undetermined significance are present in 6% of the general UK population, one estimate for a specificity of a rare genetic variant in C3 glomerulopathy is 94%, giving a positive predictive value of such a finding of only 30%, which is clearly not actionable in a clinical setting. And even if only variants with a certainty of 99% felt to be pathogenic, the likelihood that one reported actually caused disease in a patient is less than 75, which is not clinically actionable for the sort of interventions that one normally undertakes with Mendelian genetic results. So what I've learned from this work is that variants of undetermined significance are not clinically actionable in C3 glomerulopathy. I also don't think the data support clinical genetic testing in non-familial C3 glomerulopathy. And it's important to note that de novo disease in a related kidney donor, as is sometimes reported in atypical HUS, has not been reported in C3 glomerulopathy. These are very different diseases. And finally, genetic tests for familial C3G that are interpretable for clinical decision-making, i.e. not research tests, based on the current literature, these are assays for structural variation of the CFHR1 to 5 genes, biallelic CFH loss of function variants, and possibly the known C3 variants that cause a gain of function defect. Clearly, it remains possible that a broad range of complement gene variation could affect the risk of C3 glomerulopathy, but currently evidence is lacking to support causation of Mendelian C3G outside the specific instances that I described above. However, it's also true that as more adequately controlled research-based genomic testing is done, the conclusions above might need to be revised. I'd like to acknowledge the patients and their clinicians who participated in these various studies that have been undertaken across the world, and also my various collaborators. Thank you very much.
Thank you very much, Danny, for this fabulous presentation. It was extremely interesting, and I will now discuss a much more common disease, which is ADPKD, which is more common than T3 glomerulopathy. And I would like to thank the KDIGO for giving me the opportunity to discuss the clinical implications of genetic testing in ADPKD patients. I have no disclosures. ADPKD is characterized by the development of bilateral fluid-filled cysts in the kidneys. ADPKD occurs in approximately 1 in 2,500 individuals. ADPKD is often considered as an easy diagnosis, and my question to the audience at this stage is the final diagnosis in all these patients ADPKD? You can see that they all have a fair number of bilateral kidney cysts, that some of these patients do have a positive family history, and that some of these patients do have renal insufficiency. And which of these individuals has ADPKD? And the answer is that, in fact, none of these patients has a classical form of ADPKD, and some have diseases of totally different pathogenesis. So the first important message is that bilateral cysts are not always ADPKD. ADPKD is a single denomination referring to too many different conditions. And I believe, and I will try to show, that genetics can help us to reframe the ontology of autosomal dominant polycystic kidney and liver diseases. Because stratifying the disease is important, and it is a prerequisite to the personalization of ADPKD patients' care. So the two major genes involved in ADPKD are PKD1 and PKD2, which encode polycystin-1 and polycystin-2 respectively, both membrane glycoproteins functionally expressed at the primary cilium. PC1 is cleaved at a G protein-coupled receptor proteolytic site, so GPS site, and the level of mature cleaved glycoforms of PC1 is associated with disease severity. Recently, the role of other genes involved in protein maturation in the endoplasmic reticulum, and we'll say the ER, has also been appreciated, and we'll discuss those. ADPKD is highly variable in terms of renal disease severity, and genetics strongly influences age at end-stage kidney disease in patients with classical forms of ADPKD. So classical form refers to ADPKD caused by variants in PKD1 and PKD2. Three large genetic categories of patients with PKD1 or PKD2 pathogenic variants have been defined. Patients with PKD1 truncating variant, here in blue, who have the more severe prognosis and reached end-stage kidney disease at the median age of 55 years. Patients with non-truncating mutation of PKD1, so approximately 1/3 of the patients with PKD1 variant, who reached the end-stage kidney disease at the median age of 68 years in green, and patients with pathogenic variants in PKD2 with a median age at ESKD of 80 years. And so these three images here illustrates the different genotype with PKD2 patients tending to have less but larger cysts with less detrimental effect on the renal parenchyma. Now, to use this genetic information at an individual level, we have developed a prognosis score that takes into account simple clinical factors. You have here sex, hypertension, urological events, together with the genetic informations. And the score ranges from 0 to 9 points, and you can see here an increasing severity in terms of renal survival from 0 in light blue to 9 points in dark red here. And so we have defined 3 risk categories, low, intermediate, and high risk, depending on the PROPKD score. And you can see that there are quite different renal outcomes as reflected by these renal survival curves, by the median age at onset of ESKD and the hazard ratio associated. We had the opportunity to confirm the predictive value of this score in the TEMPO trial. So in a part of the participants of the TEMPO trial, 749 patients. And you know that the TEMPO trial tested tolvaptan versus placebo in ADPKD patients. And we observed that there was no difference in terms of renal function decline in the patients from the low-risk group. And this suggests that patients from the low-risk group should not be treated, and also that genetic information can be used to enrich clinical trial populations with rapidly progressing patients. Now, of course, prognostic evaluation of ADPKD patients is also based on imaging, and total kidney volume adjusted for age and height, employing the Mayo imaging classification, is very important. For reason of time and given the genetic focus of this presentation, I will not go into details here, but ideally, whenever possible, combining information offered by genetics together with imaging is, in my view, very helpful. I would just like to emphasize here the importance where evaluating diagnosis and prognosis of patients with ADPKD, at the importance of looking at the images, here MRI, and not only considering the total kidney volume. The cystic pattern is important to recognize, as we know that in case of atypical imaging presentation, here, for example, asymmetrical, or here in the middle, lopsided kidneys, or on the right, atrophic kidneys. So what we call class 2 patients, according to the Mayo imaging classification. Well, in these class 2 patients, there is no prognostic value of total kidney volume, and total kidney volume should not be employed for prognosis. And class 2 patients are roughly 10% of the ADPKD patients. And sometimes, and very often, they do have specific genetic etiologies. Now, in the rest of this talk, I would like to highlight the value of genetic testing through a series of examples. So it is a 17-year-old girl with no past medical history in whom bilateral kidney cysts were identified after renal imaging performed in the context of a pyelonephritis. She had no liver cyst. And her family history, in fact, was thought initially to be negative. Her father was, passed away 6 years before from metastatic pulmonary cancer. But in fact, while reviewing the imaging, I saw that he also had kidney cyst, 5 cysts in the right kidney, 1 cyst in the left kidney. And the mother did not have cysts, and she had one 22-year-old sister whose abdominal ultrasound is pending. So my question is, does this patient have ADPKD, and would you prescribe genetic testing in this young person? So in short, we did a targeted NGS cystic panel, and this led to the identification of a monoallelic pathogenic variant in a gene called IFT140, and pathogenic variants of IFT140 have been newly described in specific forms of ADPKD, and this is what I would like to discuss now. Monoallelic variants of IFT140 have recently been associated with the ADPKD spectrum by Peter Harris's lab in Mayo Clinic. IFT140 is not a new gene in inherited kidney diseases. Biallelic variants of IFT140 cause a multisystemic CILIOPATHY with different subphenotypes described, notably the short-rib thoracic dysplasia, which combines short stature, skeletal manifestation, and chronic renal failure in childhood. It can also be associated with severe retinal dystrophy. IFT140 is a principal component of the IFTA core complex, and the IFTA proteins are responsible for DNA-associated retrograde trafficking of proteins from the ciliary tip back to the basal cell body. And so in this recent paper, 66 individuals from 38 pedigrees harboring monoallelic variants of IFT140 have been described. Interestingly, they represented roughly 2% of the individuals naive of genetic testing. And so ADPKD IFT140 is not extremely rare, and there are probably patients in every nephrology center. Age at diagnosis was 52 years, and a majority of the individuals were hypertensive with a diagnosis of hypertension, which is approximately 30 years later than in ADPKD PKD1. Some patients did have renal insufficiency in this cohort, also, although disease course appears to be milder than even in ADPKD PKD2, as you can see on the right, with PKD2 patients represented in blue here and IFT140 in red. Imaging findings are quite recognizable, as most patients exhibit few renal cysts with some very large kidney cysts. Vascular phenotypes have been reported in some individuals, but this association has still to be confirmed. So the second clinical case is the story of a 58-year-old woman with type 2 diabetes, hypertension, and obesity. Her eGFR is 50 milliliters per minute, and she has microalbuminuria, and she was referred for management of diabetic nephropathy. Her abdominal ultrasound indicated, though, the presence of bilateral renal cysts, and here is her MRI. So this association of diabetes bilateral kidney cyst was suggestive of HNF1 beta disease, and indeed a large deletion of HNF1 beta was identified, leading to further familial study and the diagnosis in her two daughters with a very typical history of recurring miscarriage due to a bicornate uterus in one of her daughters, and also a story of hyperechogenic kidneys that were identified prenatally in her grandson. Pathogenic variants to HNF1 beta can cause a multi-system phenotype, including diabetes, hypomagnesemia, urological malformations, elevated liver enzyme, and early onset gout. Some HNF1 beta patients may present with bilateral polycystic kidneys, phenocopying ADPKD. And so this multisystemic phenotype is explained by the role of HNF1 beta, which encodes a transcription factor that regulates the expression of several genes, including PKD2 and PKHD1 involved in ARPKD, so accounting notably for the cystic phenotype that can be observed in some but not all the patients. Here is the story of this 37-year-old woman with CKD stage 2, normal-sized kidneys with multiple cysts, and a positive familial history in her mother, who reached kidney failure at age 38 and had enlarged kidneys. The question is, again, if you would consider genetic testing in this family. The NGS panel was performed, in fact, and this did not lead to the identification of a pathogenic variant. And it was a shorter version of the panel that was performed a few years ago. And so subsequently, whole exome sequencing was performed in the patient's mother and an affected brother. And this led to the identification of a pathogenic variant in OFD1 in the patients and her mother. ORO-FACIO-DIGITAL syndrome type 1 is an X-linked dominant inherited disorder, almost always antenatally lethal in male, so mostly female described with OFD1. And her son, then the results of these genetic findings, makes that her son is unaffected and her daughter is at a 50% risk of being affected. OFD1 is a ciliopathy with different manifestations, including oral abnormalities such as cleft palate, digital manifestations, and polycystic kidneys with kidney failure in 70% of the individuals at very variable age between ranging from adolescence to late adulthood. And in fact, these patients had brachydactyly and syndactyly of the toes, as you can see here. And this underlines the importance of deep phenotyping in addition to genotyping. Here is a case report that was published a couple of years ago by a group from Australia. It is the story of a 42-year-old female patient who wanted to give a kidney to her 73-year-old mother, who had reached end-stage kidney disease from what was thought to be a hypertensive nephropathy. She had atrophic kidneys, the mother, with multiple renal cysts, and she was hyperimmunized. The donor has an excellent kidney function, 3 mm sized kidney cysts on the CT scan. And would you here proceed with donation? Well, the transplantation was performed, and unfortunately, multiple visible small cysts were observed, and a kidney biopsy demonstrated tubular cysts and tubulointerstitial scarring. Genome sequencing was performed in the recipient and the donor afterwards and led to the diagnosis of DNHAB11 kidney disease in the recipient and the donor. And so, in fact, DNHAB11 encodes a cofactor of the ER chaperone BIP, which is an important actor of the protein maturation unfolding in the endoplasmic reticulum. And so, including the maturation of polycystin 1 amongst other proteins. And in fact, monoallelic pathogenic variants of DNAJB11 are associated with atypical form of ADPKD with non-enlarged kidneys and small-sized cysts. eGFR decline is generally observed after 50 years, and median age at end-stage kidney disease is 75 years. Liver cysts are present in 50% of the patients, and symptomatic polycystic liver disease is rarely reported. Vascular phenotypes have been reported in some pedigrees. And so an important message is that imaging-based diagnostic criteria should not be used in DNAJB11 families. And also, we have to remember that there is no prognostic value of total kidney volume because there is no kidney enlargement preceding eGFR loss, and patients tend to have progression with interstitial fibrosis and going progressively, having progressively appearance of atrophic kidneys. Several genes involved in the N-GLYCOSYLATION pathway in the endoplasmic reticulum have been linked to the ADPKD spectrum in the past few years. Pathogenic variants of GANAB are associated with mild form of PKD, with usually an excellent renal prognosis. Polycystic liver disease can be severe in some GANAB patients, and intracranial aneurysm were reported in some pedigrees. Two other genes involved in the synthesis of the N-glycan chain have been associated with the ADPKD spectrum, ALD9, with a phenotype overall milder than classical ADPKD, but cases of kidney failure which reported in some individuals. There seems to be quite an important variability in terms of disease severity. Liver cysts can be present, but to date, no severe polycystic liver disease have been reported in patients with ALD9 variants. And monoallelic variants of ALD8 have been initially associated with polycystic liver disease, but may present in individuals with predominant polycystic kidney disease. And again, disease is usually milder than classical forms of ADPKD, but there is quite a large part of variability, and some patients can have a significant involvement, significant polycystic kidney or liver disease, and some patients do develop renal insufficiency. So to conclude, this figure illustrates the overlap of disease categories once thought to be completely distinct, and also shows that the genetic spectrum of ADPKD keeps expanding. So of course, there are here genes directly associated to the ADPKD spectrums, and genes involved in other differential diagnoses that can mimic occasionally ADPKD presentation. So takeaway messages: genetic testing in ADPKD patients provide diagnostic and prognostic information and can help to reclassify the different forms of ADPKD. Over 15 genes are associated with the ADPKD spectrum or with differential diagnosis. I would say that in 3 to 5% of the patients with a clinical diagnosis of ADPKD, genetic testing leads to diagnosis reclassification, and so this is important. Further genetic heterogeneity may account for genetically unresolved family, which are currently 6 to 8% of the cases. Recognizing the genic and allelic variability of autosomal dominant polycystic kidney diseases is important as it helps identifying rapidly progressive disease requiring treatment, and may also differentiate patients for specific therapeutic approaches. And I hope that we will move toward a unified disease terminologies, maybe similar to what was proposed in AETIOLOGY, because two-part naming comprising both the clinical condition and the gene name can provide clarity to both practitioners and patients, and this was underlined in the recent controversy conference report, the KDIGO of CKD and genetics in CKD. I would like to thank all my colleagues and collaborators, and especially Yann Lemeur, Marie-Pierre Audrezet. I would like to thank Hugo Lemoine and Luan Rowe, the Genki study investigators, and all the very nice collaborators with whom I'm happy to work. And I would like to thank you all for your attention. And now we will move on the question and answers.
Okay, thank you very much for those presentations. Now we'll move into the questions and answer period.
Thanks, Emilie, for that wonderful talk. It was extremely interesting, and there are a few questions coming through on the chat. The first question I can see here is to ask, what is the diagnostic yield of genetic testing in polycystic kidney disease?
Thank you very much, Danny, and thank you for this question. So I would say it depends, of course, of the population who is being screened. If genetic testing is performed in a population of very typical ADPKD with positive familial history and large kidneys, then the diagnosis yield would be over 95% in terms of genetic testing. Whereas if you include patients with more atypical presentations or without family history, I would say that it can be between 70 to 80% of diagnosis yield.
Wow, so pretty high in all groups that you test in. So given the strong likelihood of finding a genetic diagnosis, and also the very strong genotype phenotype correlations that your work has shown, as well as the use of genetic diagnosis for reproductive interventions and other things in clinical medicine, are there any groups of patients with polycystic kidney disease that you do not think benefit from genetic testing?
Well, as you mentioned, we tend to perform genetic testing largely in ADPKD, both for diagnosis and prognosis purpose. We don't usually perform genetic testing in asymptomatic patients under 18 years of age. And also some clinicians might think that it is not really helpful to perform genetic testing in individuals who have already reached ESKD and who don't have relatives alive that would benefit from cascade screening, but this is a very singular situation. So I would say we tend to do it largely, and I would say that of course it depends on the availability of genetic testing in ADPKD, and I would mention that it is particularly important, to my opinion, in individuals with either no familial history or atypical imaging presentations or extra-renal findings, or sometimes in patients with a positive family history but a kind of atypical family history with no non-large kidneys and so on. Thank you for this question. So my turn, we presented two very different disorders in terms of contribution of genetic etiologies. And my first question would be, when should genetic testing be performed in the evaluation of patients with C3 glomerulopathy, to your opinion?
Yeah, I mean, that's a tough question to answer, but I'm coming round to the view that it's best used, genetic testing in clinical practice is best used when targeting people with from groups with a particularly high probability of having an underlying Mendelian basis of their disease. And that would be people with a family history of C3 glomerulopathy. It might be people with parental consanguinity, because we know there are some recessive causes. And I think those would be the groups in which monogenic cause would be enriched compared with most C3G.
So my understanding is that you would not be in favor of doing it more largely. And do you think there are potentially harms in performing systematic genetic analysis in patients with C3 glomerulopathy?
Yeah, I mean, I think there's a distinction between doing something as a research project to investigate what the genetic architecture of a disorder is, and using it as a way of getting clinically actionable information for an individual patient. And that's really the purpose of genetic testing in clinical practice. If you identify or ascertain a genetic risk factor that isn't necessarily causal for the disease, it's not really clear how actionable that is in most circumstances. So where there's really robust statistical evidence that a genetic risk factor has a causal role and the strength of that causative effect is known, so that's APOL1 disease or perhaps the common genetic variants associated with membranous nephropathy, then I think one can build a case for offering that as a clinical genetic test, although that's far from straightforward. And that's a very different situation to a Mendelian disease, where one is then thinking about predictive testing in ostensibly unaffected relatives, making transplantation decisions, pre-implantation genetic diagnosis, which clearly, if you get the wrong genetic variant, that's pretty catastrophic and a much worse outcome than not identifying a genetic variant. So I think that one factor is the disease likely to be monogenic, and how likely is it? And the second is that if you offer genetic testing to a group where the prior probability is very low, it makes interpretation of variants extremely difficult, because what one might see is so many false positives, that is, people who have rare variants that aren't actually causal for the disease, but that sort of drowns out the sort of true positives where the rare variant is causal for the disease. And that's where I've sort of evolved to the position where I would favour targeting groups in which a Mendelian cause is enriched.
Thank you very much. This is very clear. And I also wanted to ask you a more general question about diagnosis workup in C3 glomerulopathy. It is mentioned, and I think it's also the case in the KDIGO guidelines, that monoclonal gammopathy should be searched for after 50 years of age. Would you restrict this analysis in individuals above 50 years of age, or not?
So no is the short answer. I'm not quite sure of the wording of those particular guidelines, but clearly monoclonal gammopathies are commoner in older adults. But we've seen C3 glomerulopathy associated with monoclonal gammopathies in people in their 30s, and there are reports of people even younger than that in whom those have been identified. And my personal experience is actually pretty good outcomes in people with C3 glomerulopathy and a monoclonal gammopathy, where effective treatment for that monoclonal gammopathy is then administered. That's not quite the same as having clinical trial data to support that. So, and I'd also take the view that if you find a monoclonal band in a young person who's also got C3 glomerulopathy, that's much more likely to be causal than finding a monoclonal band in a much older person, where, of course, they're become so common in the population that it's less clear that it's actually causally related to the disease. So, yeah, I mean, my practice, and I'm an adult physician, is to test monoclonal gammopathies in everybody, and clearly we don't see it in everybody with C3 glomerulopathy, and we don't see that in the very young adults, but certainly in 30-year-olds, 40-year-olds, and over 50s, we do see it.
Well, Thank you very much. So targeted genetic screening and large indication for searching for monoclonal gammopathy. Thank you. Well, I think we've reached our time now. So this was a very nice discussion, and thank you again. And thank you everyone for attending.
Thank you, Emilie. It's great talking to you.
On behalf of our audience, I want to thank our presenters for a great presentations today. And thanks to our audience for your submissions of questions as well as your attention today. Note this webinar was supported by an unrestricted educational grant from Natera. At this time, we will end the webinar and you may now disconnect.